Okay, I think we'll get started. Good afternoon, everyone. My name is Mehreen Hassan, and I work in education at CAMH. I hope you're all enjoying the conference, and I'd like to welcome you all to this session on perinatal OUD management. And I'm really pleased to be here to introduce our speaker for this session, Dr. Erin Lurie. Dr. Erin Lurie is a family doctor at St. Michael's Hospital, where she works as a family physician in primary care, as well as in general addictions medicine and perinatal addictions. She serves as the perinatal substance use lead at the My Baby and Me Clinic, a perinatal and postpartum program aimed to support women in pregnancy and families postpartum who have active or previous substance use histories. Additionally, Dr. Erin Lurie is the current program director for the Enhanced Skills Training Program in Addictions Medicine at the University of Toronto. So thank you everyone for joining us, and I'm going to pass things on to Dr. Lurie. Thank you.
Thank you so much for introducing me. Oh, goodness, sorry, I pressed the wrong button already. I got to share my slides. Okay. All right. So thank you all for joining this session. Feel free to pop some comments into the chat as we go. And I don't intend for this to be overly formal. If questions come up, I'm happy to answer them as we go. I'm going to give you a bit of overview on considerations for pregnant patients with opiate use disorder. This presentation has not received any financial support, and there's no conflicts of interest. I also myself have no commercial interest to disclose. My hopes in going through this presentation with you all today, it's a bit jam-packed with information, so we'll try and get through it all. But I want to characterize opiate misuse and use disorder in pregnancy in Canada, think about some general considerations generally for patients who use substances if and when they become pregnant, and then focus a little bit more specifically on opiate use pregnancy management and specifically on opiate agonist therapeutic options as well. So what's the incidence of opiate use disorder in pregnancy? We don't have great data, and part of that has to do with just how we even collect data in itself. So this is probably the best data that we have in Canada using the Child Tax Benefit Registry, and I'm sure you can understand that that would be biased by even those that utilize the child tax credit and those that have the capacity to respond. This was a survey study of 13,000 women, about 7,000 responded, and a total incidence of opiate use during pregnancy. And this, they did not clarify illicit or just regular prescribed opiate use, was around 1.4%. There's a bit more robust data from the states. So this is SAMHSA data. So again, survey data that is collected in the states. And this is data from their statistics analysis from 2017, 2018, and 2019 and 2020. They show an incidence sort of on par with what we've seen in Canada, maybe perhaps decreasing, but also possibly biased in terms of how they collected data, especially during COVID. So I think some of the data has been a bit flawed from the 2020 year and 2019 year, which they would have collected in 2020. But the incidence around the same, around 1.41% for opiate use in pregnancy in itself. This was a recent study that was put out in JAMA in 2023, and it's quite interesting because it's looking over time at is there a trend to increase risk of opiate-related overdose in pregnancy? And although not only significant in an older age demographic, in the 35 to 44-year-old age population, there was a significant increase in the rates of opiate-related overdose in pregnant individuals. You can see generally a trend of increasing numbers throughout 2018 to 2021, perhaps not surprisingly, with a very toxic and poison contaminated supply. So before I get into pregnancy, I do want to put a bit of plug in for opiate use disorder and contraception. So thinking about patients that you may be treating who are women of childbearing age, because I think contraceptive counseling for patients that are on OAT or stabilizing is exceptionally underutilized. And I'll show you some data that supports this as well. So this was a survey study of about 50 patients who were connected to a BC-specific OAT clinic. And what they did is surveyed the people who are getting OAT to understand what contraceptive practices, right, it was 80, what contraceptive practices they were using. And they'll refer to LARC or LARC or long-acting reversible contraception. So that is longer-acting contraception. So Depo-Provera. I apologize. It's actually highlighting the wrong two. It's in this slide, but it's the copper IUD, DMPA, and the levonorgestrel IUD was only 17.5%. So ignore where it says birth control because that is obviously not a long-acting reversible contraception. But what's interesting in this study specifically is that of the 80 people that they surveyed who were on OAT or opiate agonist therapy, 45% were not using any reliable method of contraception. And as a correlate, perhaps not surprisingly, of the 23 people who became pregnant, they who had unintended pregnancies, and of 46 people who had a recent pregnancy, 44 of those people, or 95%, had reported that that pregnancy was unintended. And we don't have great data on this, but we hypothesize that when people are using regular illicit opiates, there is a suppression of the HPA axis. And when people become more stable on opiate agonist therapy, they're more likely to have a reduction in this HPA axis suppression, resume their menses, and have probably an increased level of fertility. So this is a really good time to start connecting patients with reliable formulations of contraception. In this study, the women were asked about the reasons for not using a contraceptive method, and a lot of them really highlighted that they didn't worry or had never gotten pregnant before. And really, if you ask a lot of patients who are on OAT, they've been participating in maybe higher risk sexual activity and hadn't been pregnant to date, so they don't think that they can get pregnant or are amenorrheic. These patients reported that their barriers to contraception access included difficulty booking appointments and cost. But for the majority of them, 97% actually felt quite comfortable in talking to a physician about contraception. So I do think I highlight this as a unique opportunity for many people who are working with women of childbearing age. And just to highlight, the long-acting reversible contraception is really great. And the reason why we push this as a method is we know that it is more likely to be continued for patients to 1 year, 2 years, 3 years after initiation compared to non-long-acting reversible contraceptive methods. And so we also highlight to patients that when you utilize a formulation for contraception such as this, the return to fertility is quite rapid afterwards. So if and when you desire for pregnancy in a planned and organized way, this can be reversed and pregnancy can be easily achieved. My last harping on contraception is just to think about some of the barriers that sometimes we put into place for contraception. Patients don't have to have STI testing before they start contraception. They don't have to have an updated PAP. If and when you're prescribing a contraception, you can prescribe. I've seen very often patients get 1 month, but really, realistically, if you feel comfortable to start it, just provide them with a routine and large amount of contraception to remove barriers. The nice thing for some options for patients who are on methadone and buprenorphine is if you're having them do observed dosing at the pharmacy anyways, you can link birth control pills, dispensing, things like that at the pharmacy in line with their OAT. So to help improve adherence to their medication as well. The other options to think about is if you don't have a comfort in prescribing these contraceptive methods, just like work with or couple with a clinic that might have the capacity to do this in a low barrier way. This is another study that was highlighting that long-acting reversible contraception, Depo-Provera specifically after the first injection. We do this a lot because it's just an injection, easy to do in most clinics. Most of the women didn't continue it after the first injection, but those who had Nexplanon, which is also quite easy to administer, it's just injected subcutaneously, like an implant under the skin, and those who were given the implants had a 95% continuation rate. So long-acting reversible contraception, think about it, connect with some resources to get patients to access it, and recognize that sometimes when women of childbearing age are stabilizing, their risk of fertility is likely increased, and the risk of unintended pregnancy is increased in that time as well. All right, so we've gone through before pregnancy. Let's think about general prenatal care and the substance use disorder in itself. So this was a study done by a group in Hamilton, and they also have a specific clinic. Look, it's the clinic called the Prosper Clinic, and they work with. They have a perinatal substance use clinic specifically, and they looked at patients who had unstable versus stable versus age match controls in terms of what they were getting done in their pregnancies. So those who had unstable substance use disorder had a higher risk of lower birth rate compared to the age match controls, which was 0% in their study, and 23% in those who were stable from a substance use perspective. They were more likely to have less prenatal visits compared to a stable substance use disorder population, and more likely to be lost to follow up. And perhaps not surprisingly, there was a higher rate of child apprehension and involvement of child protective services in this population as well. But interestingly, there was no difference in gestational age. Um, I didn't include it in that slide, unfortunately, but patients with unstable substance use disorder were also less likely to complete their routine antenatal blood work and ultrasounds as well. So we just know that women, of course, when they're unstable from their substance use disorder, have difficulty and barriers to access care. So what's the general approach? Is just thinking about patients from an autonomous perspective. What do they want? What are their goals? And how can we help to support that? So it's not any requirement of any program to routinely do urine drug screens. That's a choice. In pregnancy, a referral to protective services is a self-referral, which I'll go through in the next few slides. Remember that even when you're pregnant, you have risk for sexually transmitted infections. And we'll talk about the increasing rates of syphilis, gonorrhea, and chlamydia in pregnancy that has become actually quite staggering. I would guess in my current practice, about 60% of my pregnant patients have acute syphilis infections that we're treating. And recognizing who is their family is going to be maybe different and unique to otherwise patients that are presenting in pregnancy. I also really think it's important to think about how patients are accessing care, right? We know that it's difficult for patients to access care in what we perceive to be a normal and standard way, a pre-booked appointment, a separate ultrasound visit, going to a lab, organizing that appointment for the lab. So in our clinic specifically, we have a lot of ways that we can have patients have lower barrier access to care, doing point of care imaging, having access to point of care labs. I mention this for even those who are not doing perinatal care, because if your patients are regularly coming to see you for OAT care, maybe you can think of a way that's connected to your clinic to be able to reduce the barrier to access some care in pregnancy. And don't reinvent the wheel. There's many good community programs that are out there, public health nursing, other maternal support programs. Find the programs that exist in your community, partner with them, and allow them to help support bringing patients to appointment, meeting patients where they are in the community. I just want to spend a few seconds talking about child protective services. I think this is a really important thing that comes up, and I get asked quite a bit about this. So under the Child and Family Services Act, what the actual requirement and obligation of providers is under the CFSA, a child in need of protection includes a child who has suffered or is at risk of abuse, neglect, or emotional harm. But we have to remember that in pregnancy, the fetus is not a child or baby. So there is no obligation for providers to report in pregnancy. We know many of our patients who are pregnant and have substance use disorder have either had previous children apprehended or have been through the system themselves. And there's a lot of very terrible stories that I've heard from these patients from what they have maybe experienced in the past. But I also remind many of my patients is that at the time of delivery, I cannot control who may or who may not call Child Protective Services based on your medical record. And that is where a lot of the challenge becomes. What is the biggest barrier in accessing care, presenting to care, even self-referral in the pregnancy? Of course, it is the fear of apprehension, which is very realistic and very real for many patients. However, I talk to a lot of my patients in the sense that it's much easier, and there's lots of data from the program out in BC called SHEWAY, that an early self-referral in pregnancy through programs such as it's called the PACS program in Toronto through Toronto Children's Aid, patients can self-refer in pregnancy. And the reason why self-referral is usually beneficial is it gives the programs a lot of time to meet the families and lay out for the families what is required from their end for them to feel that it is a safe environment for the baby to come home to. If the referral only comes at the time of delivery, there's only hours to days for maybe even an on-call agent to make a decision about safety. And sometimes, even if we all think the environment and the situation is safe, if there is previous history, if there is an unclear picture, a temporary kinship or fostering family might have to come into place. And so a self-referral based on data from SHEWAY increases the rates of babies coming home with parents and decreases the rates of apprehension. So we spend a lot of time with patients talking about this. It takes a lot of work. We put a lot of work into building the connections, talking about why or why not it would make sense. In the end, there's absolutely no obligation to do this. It is completely an autonomous choice, but I think it's important for a patient to understand why or why they may not want to consider this. I'll give it a quick second in the chat if anyone has any specific questions, because often questions about child protective services comes up. But the most important point is there are self-referral programs that exist that patients can make, but you require consent, and referrals cannot be made in pregnancy unless there are other children in the home that you have concerns about. Okay. So what other considerations do we think about for a substance using patient population? One is infectious disease screening. And I bring this up to everyone in this chat too, because many may or may not be doing perinatal care. But sometimes, like I mentioned, people who actively use substances present to obstetrical care much less than those who do not have this. So if they're coming to an OAT clinic, it may be your only opportunity to get some baseline blood work done. Interestingly, right now as it stands, Hep C screening is not a routine prenatal screening. So we do suggest for people who are smoking opiates or injecting opiates to consider Hep C screening. We also suggest additional screening and swabs, GC chlamydia specifically, gonorrhea chlamydia, for any route of potential infection. So standard would be a urine gnat, which would detect urethritis, but it would not. We would need separate swabs for potential rectal infections and potential pharyngeal infections. And the other thing is to remember that the risk might be ongoing. And so our standard prenatal screening would be in the first trimester. But if someone has ongoing risk for high risk sexual activity, continue to screen. I suggest at each trimester and at delivery. And why are we thinking about this more? You can see here there is a significant increase in congenital syphilis. I think the number that they quote in here is an increase of 1,271% of congenital syphilis since from 2017 to 2021. And that is perhaps not surprisingly, I've seen a huge increase myself in my practice. And similarly, there have been increasing rates of chlamydia and gonorrhea in pregnancy as well. So it's important, again, to screen, to treat. Even if you're treating a patient who is not currently pregnant, but they are of childbearing age, it's exceptionally important to clearly document that the treatment happened and to connect with public health to let them know that they have been effectively treated. We see very often in the pregnant population a very unclear history whether treatment has been completed. The titers may have changed in a way that we suspect the treatment happened, but because there's no clear documentation, often patients require retreatment. And in those cases, many times the treatment specifically for syphilis would be for late latent, so 3 treatments required. And that's what I just mentioned before, just to clearly document. Other testing urine drug screens. So again, it's part of routine opiate agonist therapy if people are on take-home medication, but this should never be a requirement for accessing prenatal care. I often talk to women who are abstinent, even if they're not using opiates, and offer them the opportunity to complete routine urine drug screens if they would like to and they would feel like this would be supportive for them. Sometimes I say to them, if we think child protective services might become involved postpartum and you've been abstinent, doing urine drug screens would only support your cause. And so I've had many patients take me up on this, and I've had many patients say, no, thanks, that's invasive and it's not for me. As far as additional imaging being needed to be done in pregnancy for opiate use disorder or substance use disorder, there's no routine role for repeat imaging. However, historically, in the guidelines that we have for substance use in pregnancy put out by the Society of Obstetricians and Gynecologists of Canada, they have suggested a routine biophysical profile for patients on methadone after 36 weeks of gestational age. However, we know that those who are exposed to methadone, the fetus is more likely to have decreased fetal breathing movements, or FBM here, and decreased fetal tone 1 hour post dose. So, although we do suggest routine BPPs, realistically, often these BPPs are abnormal because of normal changes associated with methadone exposure. So now we're just going to focus a bit on opiate use disorder specific to prenatal care. So I'm sure I don't have to explain too much to this audience in what we expect in regards to opiate intoxication and withdrawal. There's nothing specifically concerning to opiate intoxication unless we get to the point of opiate-related overdose, which I'll cover in a few slides. But I always, like, for people who are like, what does the prodrome look like, especially my learners, I always think of like a slow snail, like everything is really slow moving. The biggest risk in pregnancy is opiate withdrawal. If we think about someone who is in opiate withdrawal, they have myalgias, right, which essentially are smooth muscle contraction causing that achiness in their body. The uterus in itself is also a smooth muscle. And because of that, people who are experiencing opiate withdrawal in pregnancy are more likely to have uterine contractions, which in the first and second trimester can result in spontaneous abortion. And in the late second and third trimester can result in preterm labor. The biggest risk, though, is that these uterine contractions can affect the oxygen delivery through the placenta and result in fetal hypoxia, fetal seizures, and fetal death. So it's exceptionally important to recognize opiate withdrawal in pregnancy. I have seen it be very, very under-recognized. I've seen obstetricians, unfortunately, see opiate withdrawal and think patients are coming in with the flu. And so it's very, very important to think about, recognize that this is an obstetrical emergency. So what do? You just treat the withdrawal. That's the most important thing, and you treat it with opiates. So in the short term, these patients might need very high doses of immediate release opiates. So hydromorphone, morphine, doesn't matter. Whatever opiate you have a comfort to provide in the short term that can mitigate withdrawal symptoms is the best option. And usually, the long term, we think about opiate agonist therapy, but we're doing the short and long term concurrently. But we recognize that it takes us a while to get someone to a therapeutic dose of opiate agonist therapy. So shorting acting opiates in a pregnant patient are very, very important. So practically, if you are working in an emerge, you're working in a small community, you are working as an obstetrical provider, you are working in an OAT clinic, if you ever see a patient who is pregnant and in acute withdrawal, the most important thing you can do is recognize that this is a medical emergency and that patient requires admission to hospital and management. I put this slide up here as a starting point. I think a lot of people sort of are concerned, what dose of hydromorphone, morphine do I start with? Really, it doesn't matter. Start with something and use the PAS score, which I'll go over on the next slide, as a guide to help you understand if that dose is too much or too little. For comparison, I routinely start in many patients who are actively using fentanyl, 32 milligrams. And I'll go through in a few slides why I think a lot of people who aren't comfortable with IR morphine or hydromorphone get a bit anxious at the idea of 8, 16 high doses of hydromorphone. But for people who are regularly using fentanyl, their exposure is just so much higher than that. This is the Pacero Opiate-Induced Sedation Scale, the PAS score. It's an exceptionally useful tool. I really think that this is a tool that should be integrated with every admission of opiates in hospital. It's a really quick way for a nurse to assess a patient before and after administration of opiates to determine if it's safe to provide opiates and if it's safe to continue opiates at the dose that's prescribed. And it really is just looking at how drowsy is that patient in terms of whether or not the dose that you're prescribing them is safe. And again, I bring this up. This is data from the Toronto Drug Checking Service. And again, this is older data from 2021. It's probably higher than this now. But they look basically at a sample of fentanyl and they take that small sample and equate it to what a point or 0.1 grams of fentanyl would be and how much actual fentanyl there is in that point. And roughly there is about 5 milligrams of fentanyl in each point of fentanyl. And what does that mean? If we do some really probably inaccurate and dirty math, it's roughly equivalent to 500 milligrams of morphine. So if someone's injecting that 1 point or what is equivalent to 5 milligrams of IV fentanyl, it's equivalent to about 500 milligrams of IV morphine or 1,000 milligrams of PO morphine. So again, when you're giving someone 8 milligrams of hydromorphone, it may seem like a lot, but realistically, if someone's using 5, 6, 7 points in a day of fentanyl, it's not much at all, and their dose requirements will be much, much higher. So how to cover opiate withdrawal in pregnancy? In addition to IR morphine or hydromorphone, you're thinking about your opiate agonist therapy options, which we're going to go through over for the rest of this presentation, specifically methadone, buprenorphine, Orcadian, or sustained release oral morphine. So the next question that comes up is, well, which one? There is a Cochrane review that came out in 2020 specifically looking at pregnant patients and comparing all three of these treatment options. When they compared methadone to buprenorphine, they saw no difference in treatment retention, potentially higher birth weights in the buprenorphine exposed group, and an unclear difference in the rates of neonatal opiate withdrawal, or NOWs, which we'll go through in a few slides. And there is no difference in maternal or neonatal events. And secondary to this, they suggested that either of them are reasonable first lines in pregnancy. And interestingly, this Cochrane review did not include a newer study that came out by Henri Jones's group. Henri Jones is the author of the Mother trial, which is the trial that we base the safety of methadone and buprenorphine in pregnancy on. And this study looked at a very large repository of patients, looking at about 10,000 methadone exposed patients and 4,000 exposed buprenorphine patients. And they looked to see of those larger volume of patients. So the Cochrane review was looking maybe, I think, at about 300 or 400 patients. So this is a much larger patient population set. If you look at the numbers, the dots on the left-hand side would be favoring buprenorphine, and the dots on the right-hand side would be favoring methadone, and going through the center would be no difference between either option. And you can see here that there is a reduced risk of scoring for neonatal abstinence syndrome, having a less likelihood of preterm birth, having a less likelihood of small for gestational age and low birth weight for those that had buprenorphine exposure in pregnancy. And they even differentiated between early and late exposure. They define that to be early exposure less than 20 weeks gestational age and late exposure higher than 20 weeks gestational age. So although there was no difference in the Cochrane review, this study that came out afterwards potentially shows less risk for those that had buprenorphine exposure in pregnancy compared to those that had methadone exposure when it comes to fetal size and neonatal abstinence syndrome, or what we now call NOWs. What about other treatments? Methadone versus Cadian or SROM, very small data, only one study of 48 participants. And in that study, they showed some low quality evidence that SROM may be superior for abstinence from heroin, but probably not relevant in the age of fentanyl. Buprenorphine or SROM, there was very little data that they could use to compare the two groups. So I've gone through this data, and in the end, everyone sort of scratches their head, including patients themselves, when I go through the differences in the medication and says, well, what should I do? To be honest with you, when you're working with patients, and I'm sure many of you have worked with patients who are on OAT, the patients know best. Many of them have had exposure to many different treatment options, have had friends on different treatment options, and they have a preference. The best treatment is the treatment the patient will take, the treatment that mitigates a patient's withdrawal, and a treatment that supports their goals. So, how do you think about initiating any of these medications in pregnancy? Methadone initiation in pregnancy should be offered in hospital. And the reason why is we can accelerate how we dose this medication in a hospital setting much faster than how we dose it in an outpatient setting. And it also allows for investigations for maternal health and prenatal health, as well as for referrals to be made for other consultations, like if PEDS needs to be seen or infectious disease needs to be seen. Sometimes it's quite difficult for a patient to coordinate in an outpatient setting. This is an example from a paper that I put out with my colleague, Dr. Laura Roger, looking at a cohort of about 20 patients where we did a more rapid induction based on the SHOUT guidelines. And here, using this admission rapid acceleration of methadone, we saw no adverse events for patients, higher continuation of doses upon discharge as well. And patients were by day 6 up to 70 milligrams. And for example, if you were doing this using a standard outpatient protocol for methadone initiation, on day 6, that patient would only be at 45 milligrams. So it's a way to get a patient much closer to a therapeutic dose, and you can consolidate the short acting morphine that you're giving to long acting or sustained release oral morphine concurrently with the methadone. So patients end up being pretty adequately dosed by about day 5 or day 6, which is really nice. What other considerations need to be made specifically for methadone in pregnancy? We know that there are many physiological changes that happen in pregnancy. So there's changes in the way your kidneys break down medications, the way the placenta breaks down medications, the amount of blood that you have in your body. And so we know that dose increases are often required in pregnancy. And we often talk about splitting the dose for patients in pregnancy. So instead of taking a dose once a day, taking a dose twice or 3 times a day. If you look at the studies that are actually showing split dosing, the comparison is to increased dosing. In the end, both are good options. For a patient that's been stable on a dose for many, many years, if they prefer to split their dose, they're on full take home doses of their methadone, and it's reasonable and feasible for them to split their dose, great. But for someone who's very, very unstable and you don't feel that they have enough stability to safely take medications home, it may be really challenging for those patients to go to a pharmacy 2 or 3 times a day. Or you may be concerned that if they even have their first dose observed and their second dose is a take home dose, that they might not reliably take it, or they might lose it, or it might not be safe for them to keep it in their environment. So, split doses are a great option, but if you can't do that, just increase the dose. Monitoring, again, we mentioned BPPs and NSTs can be done for patients who have methadone exposure. The newest guideline that just came out by the SOGC didn't actually make any suggestions as to whether or not this needs to be done. So for now, we continue to do these in pregnancy, although we recognize that they may be abnormal. In labor, it's very important, just continue the patient on methadone, and that someone who has tolerance to high doses of methadone, if they require analgesia in labor, they just are going to have higher opiate needs due to their tolerance. Postpartum, we've always thought that because these physiological changes that I previously described are no longer there, that patients might not need as high doses and that we should decrease the dose because of potential oversedation. Realistically, in the toxic age of the drug supply currently, I would say we probably are just getting people to what their dose should be in pregnancy, and that they do well continuing on these doses. I've almost never had to decrease someone's dose in the past 3 years in the postpartum period. So I just check in with the patient. How are you doing? How are you feeling? And keep an eye on it. And initiation of buprenorphine in pregnancy is challenging because we just said we really want to avoid withdrawal in pregnancy, right? And we know that classic or routine starts or induction of Suboxone require a patient to be in withdrawal. And so if someone is having no withdrawal and they really prefer to be on Suboxone, admission can be done. And so patients can have microdose starts. And there are many, many different ways to do this. And there are zero guidelines as to how to do this in pregnancy. So any option of a way to do a microdose, recognizing going slow and being cautious to avoid precipitated withdrawal is the most important thing. I have done rapid microdoses in a hospital setting, so the 0.5 milligrams Q3 hours and then increasing. This has gone okay in a few patients that I've done this with, or routine microdosing in an inpatient setting. If the patient is in a withdrawal, you could do a traditional start, or if they're a fentanyl user, you could do a macrodose start. But again, we don't have great protocols or data to guide the best way to start buprenorphine in pregnancy. And unfortunately, this presents the greatest challenge with the utilizing buprenorphine or starting buprenorphine in pregnancy. For those who are already on buprenorphine or who've successfully started a buprenorphine, again, similarly to methadone, dose adjustments are often needed. This was a study that was looking at people who are pregnant on buprenorphine, and they said to patients, why don't you dose it based on what your own the frequency of dosing within a day based on what you prefer. And they found that 45% actually prefer to be on 3 times or thrice daily dosing. And so, and it vary only about a third of the, or less than a third, sorry, 16% were on once daily dosing. So again, split dosing might be very beneficial for patients in pregnancy due to the physiological changes we mentioned before. Yeah, don't worry, Jen, I'm getting to Sublocade, I promise. In terms of the delivery method of buprenorphine, this is a really important thing to go through. So Suboxone, which is the trade name for buprenorphine naloxone, is fine in pregnancy. Historically, there was a black box warning on Suboxone because we didn't know the safety of the naloxone exposure in pregnancy. And so historically, guidelines would have suggested to switch to the mono product, which would be only buprenorphine in pregnancy. Now, this is no longer the case. The SOGC guideline, the BCCSU, CAMH, they all do not suggest any rotations, and we do not switch anymore. So this is a thing of the past. What about other delivery methods? So in Ontario, the subdermal propufene is no longer available, but for those who may or may not already be on it, it's not necessarily the best option in pregnancy, primarily because the dose of that is being delivered is static. And we know that the dose requirement changes due to the physiological changes in pregnancy are likely going to change. And so we do suggest, because there is no safety data looking at the subdermal implant, that patients might want to rotate to the Suboxone or the sublingual formulation in pregnancy if they're already on the propufene formulation. If it is and end up being continued because there's no issues with the delivery method in itself. It's more so the knowledge that the dosing is not static and requirements are often likely going to change in pregnancy. Just recognizing patients who are on the subdermal or implant formulation might require supplemental doses. So the depot formulation that we have available in Ontario is the Sublocade. And there is a black box warning for pregnancy, and this is specifically because of the Atrogel or NMP, which is the expedient. And I've had a lot of conversations with the Indivior representative about this. We do know mostly from rat studies and mouse studies that fetal malformations secondary to NMP have been seen. We don't have any data in or robust RCTs or data in pregnancy regarding the safety. So we do recommend that people who are on Sublocade be on a reliable form of contraception if they are sexually active. If they're not sexually active and you're quite confident of this, what we do suggest is to do a point of care pregnancy test at the time of Sublocade injection, because the NMP's half-life is actually quite short in comparison to the effect of the buprenorphine through the depot formulation. The exposure risk would really be in the first sort of 3 to 4 days after injection. And so I think that was probably what Jen was asking in the chat regarding contraception. So yes, absolutely long-acting reversible contraception if someone is sexually active. And if someone is not has no risk of pregnancy, then doing a point of care beta HCG at the time of the depot formulation is good. For people who, for some reason, end up becoming pregnant on Sublocade, reporting this to the product monograph manufacturer is important, and just switching them to sublingual dosing as soon as you discover that there is a pregnancy. Hopefully we'll have access and the data will be out soon, but in the States, there is another formulation. There's a weekly dosing of a depot formulation of buprenorphine called Buvidal. And the weekly formulation, not the monthly formulation, but the weekly formulation does not contain NMP. There is an ongoing clinical trial comparing the sublingual buprenorphine to this depot weekly injection in pregnant patients. I keep checking to see when that data is going to be published, and the last update I saw was that likely the study will be completed in 2025. What about other treatments in pregnancy? We have the group I most often work with would be Suzanne Turner and Maya Nader, who used to work with me at St. Mike's and have now moved elsewhere, but I still love to work with them. We've published a number of case studies looking at slow release oral morphine. We've done a case report looking at IOT, and I do have some patients on safe supply, but there is no data for any of these modalities. So I just talked to you about patients should be admitted for titration, but there are many patients for many different reasons who don't want that, and that's okay as long as they are informed about the risk. Just start opiate agonist therapy in an outpatient setting and review with them that if they have withdrawal that is not abated by their OAT or their illicit use, that they should seek care in through either obstetrical triage or the emergency department. And if you have a patient who is pregnant and admitted and you don't have an addictions team and you don't feel comfortable to start things like buprenorphine or methadone, I always just say count up how much immediate release hydromorphone morphine that you've given them, rotate it to some amount of Cadian, and then at least you can give them something to leave with from the hospital setting while they connect with an outpatient provider. And why does this matter? And why is this important to think about? Beyond the fact that we know that there's risk of opiate withdrawal in pregnancy, we know that the duration of opiate agonist therapy in pregnancy matters. So this is specifically for methadone opiate use, so this is medication for opiate use disorder. This was a study of 13,000 patients in Pittsburgh, and they looked at how long someone was on treatment for and how much that changed their risk of opiate-related overdose and continuation of treatment after pregnancy. And the longer that you are on treatment, the less likely you are going to have an opiate overdose in pregnancy. And the longer you are on treatment, the more likely you would continue the medication postpartum. So it's important for many different reasons. Now, what do you do if someone becomes so intoxicated and they have an opiate overdose? There's actually no data or no guideline around what we should be doing. We just talked about how much of a risk opiate withdrawal is in pregnancy. So what do you do to reverse the overdose? So there is potential risk of Narcan and naloxone because withdrawal is a risk. But that being said, someone who is not alive cannot gestate a pregnancy. So in a hospital setting, I always talk to my nurses, my Emerge colleagues, and most of the Emerge colleagues that I work at St. Mike's at least are very gentle with the way that they provide naloxone using IM, using very small aliquots to just lightly reverse someone and thinking about respiratory support through other modalities. But the bottom line is if you're out of the hospital setting and you don't have that capacity, you just give naloxone and then you treat the withdrawal when it happens because you need to be alive to gestate a pregnancy. So I'll spend the next 5 or 6 minutes talking about neonatal withdrawal, what that looks like, treatment, different options for that very briefly, and then I'll leave some time for questions. What are the biggest risks for the neonate who's had exposure to opiate in pregnancy? There maybe is a slight increased risk for small babies, but that's about it. There's really no long term risks for opiate exposure in pregnancy when it comes to cognition, when it comes to the well being of the baby long term, which is really good. The biggest risk is what we previously called neonatal abstinence syndrome and what we now call neonatal opiate withdrawal syndrome. And this is basically a neurological hyperactivity because babies have exposure to opiates and then no exposure to opiates. And it can, at its greatest risk, cause seizures on the baby and death. So it's very serious. And we'll talk about that in a second. As far as breastfeeding goes, for people who are on any of these treatments, it's absolutely fine and encouraged. People who are on methadone, on Cadian, on buprenorphine, if they're not using any illicit substances, it's absolutely fine to breastfeed and it's absolutely safe to breastfeed. So, how do we think about nows? The most common assessment tool that we use is called the Finnegan scale, and this is a very long and cumbersome scale that is where babies are woken up at 2 hours post delivery, and then every 4 hours they're scored on this combination of objective and subjective signs of withdrawal. And if a baby scores over 8 on 3 occasions or over 13 on 2 occasions, they receive treatment. And the treatment is typically morphine, but it can also be methadone, buprenorphine, and adjuncts such as clonidine or phenobarb. Why the score of 8? There's actually no rationale at all. It's just the consensus opinion as to what score has been historically used. How you score this, so even the every 4 hours, there's no standard protocol for how to assess and how to treat. It's basically all consensus and expert opinion. So, what do you do even before you start treatment? Many of you may have heard of rooming in. And realistically, all this does, uh, it's not it's not anything that hasn't been done in many settings before. It's just recognizing that reducing stimuli, swaddling, breastfeeding, responding to baby signals can reduce some of the jitteriness that we see in babies. And so we do this in our center when babies have opiate exposure in pregnancy. The mom and baby dyads stay in the same room until baby scores and requires treatment. And we encourage the least amount of assessments, a private room, swaddling, keep the lights off, supporting feeding, encouraging skin to skin. And we know that this reduces the rates of scoring and treatment when you do rooming in this way. How long should you be monitoring for? So we know that methadone and buprenorphine are very, very long acting. So if you look at the big study that I talked about before, the mother study, and you compared methadone and buprenorphine for how many hours it would be for a baby to score. On average, the babies with methadone exposure would score around 40 hours, and buprenorphine babies exposed would score around 60 hours. And for this reason, we suggest 5 days minimum monitoring for babies who have methadone exposure and 7 days of minimal monitoring for buprenorphine exposure. It's also important to think about because if babies are scoring on hour 2, hour 5, hour 7, it might not be from the methadone and buprenorphine. It might be from the illicit opiates they were using. It might be from the SSRI they're on, cigarettes, marijuana. For this reason, I have a conversation with moms about all the other exposures, concurrent marijuana use, smoking, what other things might cause jitteriness that might mimic neonatal abstinence syndrome or NOWS. And to try and mitigate what you can reverse. In the end, if you have opiate exposure, you just treat whenever babies become symptomatic because you really can't differentiate between one or the other. The next question that often comes up is, does the dose matter? So I see all the time patients don't want to increase their doses. They want to stay on as low a dose as possible. But there is this great study that came out that looked at the different doses of methadone and buprenorphine and showed that the total dose someone is on of methadone or buprenorphine has no implication on the rate of NOWS. So again, the best dose that someone can be on is the dose that mitigates with complications from withdrawal. And if you're on 90 or you're on 30 of methadone, there's no difference in the rates of those who score. So there's no difference in babies that will or will not score. Where there is a slight difference was another study that came out afterwards. And this does show that for the babies that do score, those that are on higher doses, the parents that are on higher doses of treatment of methadone, were more likely to have longer durations of admission and require more morphine. So, if you're going to score, it's possible that you'll require a higher dose of treatment if you're on a higher dose. But again, because it doesn't have any impact on the rates of scoring in itself, I still think the most important thing is to be on the therapeutic dose that's going to stop your cravings, stop you from using illicit opiates, and abate withdrawal. So we talked about the Finnegan score. So Finnegan score is waking baby, assessing withdrawal, and then in the absence of supportive measures. So you're not like doing anything to mitigate it. You're just like looking at the baby and saying, what withdrawal symptoms do you have? And Eat, Sleep, Console is a new study, a new methodology that has come out that basically says before we start to treat baby, we should do everything that we can to minimize withdrawal symptoms such as feeding baby, consoling baby, swaddling baby, doing skin to skin. This is the Finnegan scoring system. It is cumbersome, it is long, it is subjective, but it is the tool that is most utilized. This is Eat, Sleep, Console, and it's a bit more intuitive, but it does require someone to be able to do all these mitigation strategies, including like consoling, swaddling babies, which if there is no active parent or the parent is very unstable, sometimes this can be very challenging to facilitate. But essentially, they're just, can you feed the baby? Can you get the baby to sleep? Can you console the baby? And if you can't, then the babies require treatment. And we do know that when you use an Eat, Sleep, Console approach, that babies require less treatment and babies require less morphine and shorter durations of admission to hospital in comparison to using a Finnegan scoring system. So the last thing I'll just quickly talk about is that NOWS is specific for opiates, and it's scale. Basically, I've seen many times where babies have exposure to other substances and Finnegan scores are done or Eat, Sleep, Console scores are done, but they're not useful because those scores are used to think about when you would initiate morphine. So if someone else is, if babies have crack or cocaine exclusive exposure, doing these kinds of scoring systems isn't helpful because those scoring systems are only helpful to initiate morphine and treatment for morphine. But recognizing that there are other things that can mimic it. And so what can you reduce? Smoking cannabis, all these kinds of things to potentially mitigate things that can mimic it. So this is the key things that we talked about in this presentation, also highlighted in the recent JOGC guideline that came out late last year. We went through most of this. And just a quick summary here that I'll leave up for you guys if any questions come up about considerations in pregnancy, the neonate, and specifically treatment. Thank you all for your time. If you do have any patients in the Toronto area, this is just some information for the clinic I run through St. Michael's Hospital. We have a low barrier clinic. The number for my social worker is on there. My email is here. Please don't ever hesitate to be in touch if you have patients that you might think would benefit from specific prenatal substance use care. We're happy to see anyone.
So thanks so much for your presentation, Dr. Lurie. Thanks for sharing your knowledge, your experience, and your expertise. It was a really interesting and informative presentation. Thank you. And I just want to thank all the participants as well. We've reached the end of the day. We have a few minutes, so if you have any questions, please feel free to post them in the chat. There's some feedback for you about how great your presentation was, and
So there was a comment earlier on I saw, sorry I didn't get to it at the time, but what if the pregnancy is at a late stage and you anticipate there's a chance they may not be born in the safest environment? Yeah, if the patient does not consent, doesn't matter when it is in the pregnancy, you cannot refer. You can only refer at the time of delivery. So you can write a note saying, like, I have concerns to the stability and safety of this mom to parent. If you think they might be like going to a different center or might not present to care, you can definitely highlight what your concerns are in terms of the potential safety when the baby's born. But it is not legal to contact Child Protective Services while still pregnant unless there are other children in the home.
Yeah, thank you. Thanks for answering that one.
No worries.
And then there's a question about, is it possible to get a copy of the slides? I believe that they will be sharing recordings and a copy of the slides following the presentation, along with a link to the evaluation form. So any feedback that you have on any of the presentations for the day, please feel free to share that as well. So we've reached the end of the day. Oh, there's another question here. I may have missed it. Breastfeeding while in OAT. Are there any issues with higher OAT doses, or what to do if breastfeeding is not started right away after delivery?
Yeah. So again, I guess Perry, is your question. So no, it doesn't matter what dose you're on in terms of being on OAT or not. The biggest issue I find is more, what do you do, let's say, if someone's like pumping breast milk and then tapering, right, their methadone. And so what do you do about the like giving them the breast milk from when you were at 120 milligrams if you're now at 30 milligrams, right? Because babies essentially have the tolerance to the breast milk that was before. So no, there's no difference, like no adjustments that need to be made based on the dose. It doesn't matter what dose you're on. It's absolutely safe because that's the dose that the baby is essentially tolerant to. The concern really, for me at least, is like if the dose is potentially tapering. And the other thing I didn't mention in the slides is if the mom, for whatever reason, does not want to breast or chest feed, or there is concerns about the safety, like let's say they're still using illicit opiates, or they have other reasons why they may or may not want to breast or chest feed, you can give bromocriptine within the first 24 hours of delivery for lactational suppression, which is beneficial. Like, it's really traumatic if the baby's recently been apprehended and then 7 days later the mom becomes completely engorged with breast milk and the babe's not in their care. That can be really traumatic for moms as well. So offering lactational suppression for those that may not have the opportunity to breastfeed can be a really important thing too.
Thank you. Thanks for answering that. So we've reached the end of the day. I want to just thank everyone for joining this session. Thanks so much for sticking it out till the end of the day. I hope you enjoyed the session. I hope you enjoyed the conference. And I hope you all have a wonderful weekend. Thank you so much. Thanks, Dr. Lurie.
Thank you.